I would now start to introduce our distinguished speaker, Professor Sebastian Bauhoff. He is an assistant professor at the Global Health and Economics at the Harvard Chan School of Public Health. And he received his PhD in Health and Policy Economics from Harvard University and previously held a position as a senior fellow at the Center for Global Development, which I know from other collaborations in exciting research fields. Sebastian's research focus is on innovations in healthcare financing and service delivery. And he's interested in how access can be increased and efficiency and quality of care in low and middle income countries. So something that keeps us busy in research, also in a number of projects. He's particularly interested in interdisciplinary research that applies rigorous empirical methods to secondary and administrative data. In our preliminary exchange, we talked a lot about integrating spatial data with survey data. Perhaps he will talk a bit about that today. He has been doing that kind of work all over, a lot in Africa and Asia, including Cambodia, Ethiopia, Nigeria, Rwanda, and Tajikistan, and probably many more. I'll stop here and let him tell his exciting work by himself. Sebastian, thanks a lot for making time and be with us today. I hope we have an exciting discussion afterwards.
Thanks so much, Jan and Joachim for inviting me, and Jan for the nice introductions, and also to Hannah for helping with the logistics. It's really an honor, and I'm delighted to be here and sort of have a chance to get some feedback from all you and some comments and some discussion. So I will talk today about performance-based financing in healthcare in low middle income countries. And I know that's a little different from other talks that you might have seen in this series, but I hope it's interesting to you and maybe stimulating for your own research and work. So my goal for today is just to give you sort of a big picture overview of where we are with performance-based financing, and specifically in primary healthcare settings. And my main message for you, main takeaway, is that PBF is an interesting and pretty disruptive approach to healthcare financing. It has made some positive contributions, but it's also not a silver bullet. But maybe more importantly, there's a lot to be learned from the PBF experience so far. There's been a lot of experimentation with PBF, and there's a lot we can learn from those PBF experiments and pilots. So I set up the talk in sort of 4 pieces. I'll first describe the bigger context and motivation for using PBF, and then explain a bit what these PBF schemes look like in practice. Then I'll talk about the current evidence that we have on PBF and highlight some opportunities for research and collaboration that we can then use to discuss a bit more. I'll try to do all this in about 30 minutes, so I'll go pretty fast, and I won't go into too many of the important details, but you're welcome to interrupt me with clarification questions, and if you have any bigger items, then of course we can also spend some time at the end. But let me start by just motivating PBF as a policy instrument and then giving you some of the details of what these schemes actually look like. So many of you have probably seen charts like this one on maternal mortality. In a nutshell, we've made a lot of progress in the last 2 decades with improving health outcomes worldwide, including in low and middle income settings. But there's still a long way to go, especially in sub-Saharan Africa, where many basic health indicators are still pretty bad. Now, one of the issues is that the utilization of healthcare services is quite low. And here on the left, I put an example of births attended by skilled staff. And you can see this is a pretty sad picture. Many countries don't do very well in this very basic service already. Another issue is that the quality of care is also low. So on the right, I have put an example from Ugandan maternity clinics on what health workers actually do in labor and delivery care. And you can see that even basic things like checking blood pressure or taking vital signs are often not done in these kinds of settings. So even if people do get to the healthcare facility or they do get care from a skilled attendant, it's often not as good as it should be. So you could look at this and say like, well, you know, this is healthcare, and does this really matter for health outcomes? And the answer is yes, it does. And so this chart shows what we could do to tackle mortality among mothers and newborns. At the bottom here, you can see is the share of deaths that we could prevent through, for example, better public health measures and so forth. And clearly that's an important component of addressing this excess mortality. But at the top, you can see that healthcare itself is also quite important. And so quality of care, in fact, turns out could make quite a difference. So if we can improve quality of care, there's a good chance we could bring down mortality rates quite a bit. But what this means, of course, is that we have to improve things that once people are actually in the healthcare facility. So not just getting people there, but actually doing better once they're in the facility. So let's be clear, these are really difficult environments that are under-resourced in many ways. The infrastructure is bad, equipment is missing. They often don't have basic supplies and medicines. Budgets and salaries don't arrive on time. So these are really sort of tough work environments. And I put here on the left some examples from Uganda and Tanzania that you can see even basic things like clean water or stethoscopes are missing in many of these places. And sort of addressing all that, of course, is difficult and is expensive, but at least there are some things that we can do to improve things relatively easily and at relatively low cost. So here's a graph from earlier that I showed you how much health workers do in labor and delivery care. And so I showed you only this sort of blue bar, which is what workers actually do. And I added to this in this graph data on what workers actually know they should be doing. So you can see that there's some basic things that don't require a lot of equipment, like taking pulse, taking blood pressure. These are things that can be done even in settings with very limited resources, but workers don't seem to do them, although they know that they should do them. And so this gap between what they know and what they do raises the question of how we could get health workers to at least do what they know they should be doing. And so here's an interesting study from India that compares the behavior of the same doctor. So these are trained medical professionals, literally doctoral degree, when she's observed in private setting or public setting. So many of these doctors in India and other places both operate and work in the private sector and public sector, and also have a private practice on the side, dual practice. And this is using standardized patients. These are enumerators that are trained to present with a particular diagnosis in a standardized way. So these are really comparing sort of across identical patients in these two different settings. The doctors don't know that they're being observed, so they do what they would do in their normal practice. And you can see that for the same patient that shows up to see the doctor in their public practice, they get pretty lousy care. And if they show up, the identical patient shows up to the same doctor in their private practice, the care is much better. So when it comes to things like giving a diagnosis in the first place or actually having the correct treatment, these are all things that do much better in the private setting. Now, just to be clear, this is still pretty bad, right? So if you go to a private, same doctor in a private setting, you only have a 50% chance of getting a diagnosis and maybe just a 60% chance that the diagnosis is correct. So that's still pretty terrible. But if you look at the difference between the public and the private practice for the same person, it suggests that at least that very same person could certainly do better if they were in a different setting. Now, there are many differences in these public and private settings, of course, but one of the important ones is financial incentives. Clearly, in private practice, doctors have much more incentives to do better quality, to attract more patients and get more money. So that suggests that tweaking incentives could actually be helping us to make some improvements on quality of care and maybe also on quantity of care. So let me sort of step back for just a moment and sort of summarize where we are. Quantity and quality of care are low, but they seem to be important. There are many reasons why these things are bad, but the no-do gap suggests that at least providers could do better. And there's some evidence that suggests that providers actually can do better and do better if they have the right incentives. And so this is sort of the base motivation for performance-based financing, is to say, well, what can we do about it? One thing we can do pretty easily is to change incentives. And that makes the sort of changing incentives a very appealing policy lever. There's nothing infrastructure-wise that you need to do or nothing new training or something like this. You just change the way that people are being paid. And the idea is that this would lead to higher performance. So this is where PBF then comes on the scene. And just sort of to give you a brief overview of what these programs look like and sort of what the idea is behind them, is a strategic purchasing mechanism to increase the performance of service providers by paying them for specific services and specific delivery or specific level of quality of care. That's very different from traditional financing, which relies on line item budgets and sort of budgets that are not tied to actual performance. Now, these PBF programs are added to existing systems. They're not intended as replacement for existing financing arrangements. The idea is just to pay providers for performance on the margin. So to make sure that, on the margin, they pay attention to some of these things that we as policymakers or decision makers or observers think are important. It could be quantity of care or quality of care. And there are sort of two ways to think about performance-based financing. One is sort of the very narrow, maybe economics 101 view, is a sort of contracting arrangement, a specific way of contracting with providers that's sort of solving this fundamental problem that we don't really observe what health providers do in their clinics. As a decision maker, policy maker sort of wants to provide healthcare services, but can't really observe what these providers do. They could do more monitoring, and many countries, of course, do that. But one other thing they could do is just to make sure that the incentives are aligned so that providers would produce anyway what the policymaker wants. So sort of the narrow economics view is this is a solution to a fundamental principal agent problem in healthcare. But there's also a broader view that PBF is sort of a part of a package of supply side reforms in healthcare, and maybe in fact sort of a way of introducing reforms into the system. So it's an entry point for larger reforms. And that's something we'll come back to in just a moment. Now, the idea of PBF, of course, is nothing unique to healthcare, and many of you might be familiar with things like output-based aid or RED Plus, other sort of performance-based schemes in other sectors, or even with conditional cash transfers in healthcare. All these are sort of based on the same idea of using incentives to align sort of the objectives between whoever provides the service or receives the service and the sort of policymaker interest. Now, PBF is sort of located in this little corner over here. It's really about paying healthcare providers rather than people or countries or organizations, and it's based on fee-for-service payments. So these are sort of payments per unit, and I'll sort of talk and programs actually look like more specifically. But you can see that PBF is a little bit different than other maybe output-based aid or so these other results-based financing program, and even within health is sort of a subset of results-based financing that's really targeted at the supply side at healthcare providers rather than anything else. So here's a schematic of the stereotypical PBF scheme that you might find in these sub-Saharan African countries nowadays. This is the payment formula, and it has two pieces. On the right, this is the quantity piece. And for each targeted services, we just multiply the number of services that the health facility has provided with the sort of per unit reward, and that gives us the quantity bonus. So we'll do this for every single quantity indicator that is incentivized in the program. And then this is scaled by some quality index. So this ranges normally from 0 to 1. And if you produce quality that is sort of subpar, that is not excellent quality, you get paid less in the bonus. So it's just a way of sort of paying people for quantity, but adjusting, sort of scaling down if the quality is too bad. I also put down here how this actually works in practice. The health facility will report the number of units that they have provided. This gets checked by the district. So once in a while, the district shows up and looks at the registers and checks, confirms that the facility actually reports accurately. The district also administers a quality of care checklist every quarter or so. We can look in a moment in some detail what this actually entails. But the idea is basically that facilities report and districts check, and then there's a third party, sort of independent entity like a local NGO or sometimes an international accounting firm that goes and audits these things on a sort of random basis. So they would maybe take a 20% sample every quarter, and they would visit these facilities, trace patients into the communities, and confirm that they actually received the services that the facility said they provided. Now, this bonus is then paid to facilities. So it's not paid directly to individual workers, but it goes to the health facility. And then it's split between the facility and the worker. So some of the money goes into the facility budget, and some of the money goes to individual workers as a performance bonus. Now, I said earlier that these bonuses are sort of supplemental finance, but they can be quite substantial, somewhere between 25% of a facility budget in a place like Rwanda and a good chunk of a nurse's salaries, and for example, in Burkina Faso. So these are relatively large sums of money. Maybe importantly, these monies can also be used in a more flexible way. So normally these sort of line item budgets that facilities get are very restrictive in how they can be used. But these PBF bonuses often allow more flexibility. So it's possible, for example, for a facility to use this extra money to buy some missing supplies or do some community outreach or other kinds of things. So it comes with a certain amount of flexibility and discretion. And that's actually quite important, I think. Now, the average PBF scheme in sort of for maternal child health has about 18 quantity indicators. So that's a sort of manageable number, and has about 125 quality indicators, which of course is a lot. But let's take a look at what these quality indicators at least look like to give you a sense of what is the kind of stuff that these programs actually target. So here's I put the sort of top two quality indicators for maternal, neonatal, and child health. And you can just see that, some of these measures are sort of pretty basic, like is the register completely filled out? 44% of schemes have this as a measure. It's a quality of care measure. There's some more sort of process-oriented things. Is the partograph completed? Is this a labor and delivery tool? Is that properly completed? All deliveries carried out by qualified personnel, and so forth. But overall, most of these quality measures are sort of structural measures, like is a certain piece of infrastructure or equipment there? Is it functional, yes or no? Relatively fewer are what we would call process measures, or the process of care, and very few are things like outcomes. And outcome could be both maybe health outcome, but could also be things like patient satisfaction, similar stuff like this. Now, just to sort of maybe make the point that PBF programs don't just change incentives, but they actually come with a lot of other changes that are useful in their own right. So when I said earlier that, you know, sort of the broader view of PBF is maybe that it's an entry point into larger health systems change, that's sort of part of it as well. So here I put some common bottlenecks that sort of hold back performance in primary healthcare settings, and I mapped them to specific aspects of PBF schemes. So you can just like look through this list and, for example, see that these additional resources, as I mentioned, can be very useful. So there's sort of lack of money and lack of equipment, but the bonus payment can be used by the facility. The facility can decide how to use them, sort of flexibly to buy some missing supplies or something of the sorts. I think one interesting piece is this the supervision part. A lot of health facilities actually don't get the supervision they're supposed to receive. The district teams often do not go to the health facilities as often as they should. But in PBF, they have to, because they have to administer the quality of care checklists. So every quarter, the district actually has to go to the facility and sort of engage with the facility on what they're doing and give them advice and do some supervision. And funny enough, I think it gives the facilities also a chance to actually tell the district what they want support with. So they can tell them, like, look, my roof is broken. That's not something I can pay out of my PBF bonus, but it impacts how much I can earn. Therefore, I need you to come and help me fix this. So I think it sort of sets up an accountability channel that the district is now responsible for doing its work as well, which is sort of interesting wrinkle on the PBF. But anyway, just to say that in practice, PBF is more than just incentives, but sort of a shorthand for some larger set of changes and some multiple levers that actually come along and sort of might lead to changes on the supply side. Now, so you have an idea what these schemes look like, and I think that's sort of pretty interesting and certainly a departure from what traditional health financing has looked like. But PBF is not just an interesting innovation, it's also important on the policy level because it's everywhere and there's a lot of money involved. So PBF made an appearance on sort of in health policy in the early 2000s with some initial pilot programs in some places. But then in the mid 2000s, there was a very influential randomized controlled trial of Rwanda's national PBF program. And that really sort of set the PBF wheels in motion. In 2007, the World Bank established this Health Results Innovation Trust Fund, which is very large and a very active trust fund that supports PBF pilots and research in 28 or so countries. Many of them in Africa, and you can see sort of really these PBF screens in Africa, they're pretty much everywhere at this point. I think one thing that's interesting about this HIITF is that it has a mandate to evaluate and sort of generate knowledge and share knowledge. And a lot of what we know today about PBF programs is actually based on programs that are supported by HIITF, which I think, you know, there's a lot of evaluations that come out of it and a lot of chances to study these programs that the World Bank has supported, especially in African countries. And just to say that these pilot programs are also quite diverse. I sort of talked about PBF as sort of as an alternative to just business as usual, but really what these pilot programs do, they also test sort of multiple ways that PBF can be implemented and sort of try different aspects to see which aspects of PBF actually matter in practice. And so you can see that, for example, here in Cameroon, this PBF pilot tried 4 different arms. There's the business as usual thing and the PBF arm, and then there's other stuff that they also compare with. And of course, sort of making comparisons across these different arms gives a lot of insight into what works with PBF, what doesn't work, what are the kind of things we should be paying more attention to. And even if you're not interested in PBF, I think these comparisons across these arms can be even useful if you're not sort of a PBF aficionado, as it were. Now, you're all hyped up and you all want to know sort of what's the evidence on PBF. But before I get there, let me pause for a moment so we can cool down and sort of collect our thoughts. And in practice, as I said, I started motivating the PBF stuff by talking about incentives, but in practice, as we saw, there's a lot of different pieces to PBF programs, and these are really kind of complex programs trying to address a complex complex problems. Sort of, it's useful to think about what this actually means for evidence. So the first question is maybe where we should look for effects. And the obvious place is, of course, the targeted indicators. So whatever PBF is targeted, is there any impact on those kinds of indicators? And that's a good place to look, but it's, of course, not the only thing. These PBF programs might also impact other stuff that we don't measure maybe, or that we don't look at, maybe less tangible things. Excuse me. Less tangible things, even just like policymakers paying attention to quality of care problems, or impacts on services that are not directly incentivized. And it's actually not obvious what we should expect on this. I think the general concern with PBF has always been that if you incentivize certain kinds of services, providers will shift their effort and attention to those kinds of services and neglect stuff that's not rewarded. But actually, that's not obviously the case. You can imagine if you give incentives to a healthcare provider to check someone's blood pressure, they might also, while they're doing it, at the same time provide counseling. And even if that counseling is not incentivized, you could still see positive impacts on those non-targeted services. So it's not so clear what we should actually expect, and it's not obvious that we should just look at only the targeted services. Probably it's useful to take a bigger picture. And then, of course, we also need to get a good sense. Excuse me. Need to get a good sense of sort of what the remaining barriers to implementation are. So showed you earlier that some of these facilities don't actually have clean water. And obviously that's going to be a sort of barrier to improving anything that has to do with hygiene and hand washing and so forth. And then lastly, as we already saw from these PBF trials, sort of there's an important question like, what's the counterfactual? Now, PBF involves giving money, so it's not really business as usual. At the least we should compare it against this sort of just additional money without PBF, so just enhanced financing without any strings attached. So just to say that this is all complicated, sort of making sense out of the evidence is useful to keep in mind all these different elements. I think there's sort of a tendency in the published literature to focus on sort of a handful of indicators, normally the ones that are incentivized, and sort of not see the bigger picture. And so any of these, specifically the quantitative impact evaluations, might actually miss a few of these sort of positive and maybe negative effects of PBF. So obviously that's important to keep in mind when we look at what's actually published on that topic. All right, ready? Here comes the evidence, and I think the maybe a somewhat deflating news is it's mixed. And so here's a quote from a new systematic review that has just come out. Overall, PBF is likely to have some positive effects, might increase utilization of care, might improve some aspects of quality of care. And given these mixed effects on these intermediate outputs, it's maybe not surprising that there's also mixed evidence on the effects of health outcomes. I think there's sort of some studies that have come out and that have gained a lot of attention, just like this initial Rwanda study on PBF that sort of got a lot of attention and suggests that PBF is doing quite well. And it seems to be doing well in certain settings, in certain contexts, but it's not sort of overall across these PBF programs, there's not good evidence that it's just purely a positive thing. It's more like a mixed bag, but at least maybe there's not much evidence that it has negative effects. So I think this concern that PBF would, sort of lead to neglect of non-targeted services, might impact health workers in some bad way or communities, does not seem to come out very clearly in the existing evidence, at least. Here's some sort of other findings. Maybe obviously the impacts are most likely on services that can be influenced. So in some ways, these quantity targets include things like the number of deliveries in the facility, the number of antenatal cares, the number of women who use modern family planning methods, stuff like this. And of course, these are things that are not just in the hands of the facility or the healthcare providers. They also really depend on the patients and the local communities. And so to the degree that the facilities can influence a sort of increasing quantity of care, like through outreach or through maybe having better quality that households and patients actually want to come to the facility, those are the kind of things where we tend to see impacts of PBF programs. And again, maybe that's not surprising. It's just to say that sort of you shouldn't expect PBF to do miracles where it really is in the hand of the patients and the households to engage in the care process in the first place. But yeah, there's some role for healthcare providers, of course, to sort of bring people into the facilities. There's some evidence that households actually notice the change in the quality at the facility, which I think is quite impressive, really, if you think about it. So facility makes changes to the way that they treat patients, the way they engage with patients, the way that the infrastructure looks. They might paint the facility or something like this, and it does seem that this influences how patients seek care. So they might be less likely to skip the local clinic and directly go to the hospital to get care, and instead actually make use of the local facilities. And I think that's really quite an impressive finding, actually. And then maybe importantly, I think this concern that PBF might destroy the motivation of intrinsic motivation of healthcare providers and health workers does not seem to sort of come out in practice, at least in the evidence that we have. There's clearly some disgruntlement from workers that maybe don't get the bonus they had expected, or don't like the way that the bonus is distributed at the facility, and certainly disgruntlement if the sort of local environment and the facility management is not conducive to actually performing well. So I think if anything, then performance-based financing sort of maybe clarifies to people that there's something wrong with their facility, and it's very frustrating, of course, if workers can't make any improvements that they would otherwise like to have made. But I think in general, it's actually pretty sort of positive picture, I think, for all the concerns that people had with performance-based financing sort of impacting the health workforce. It does seem that it's not such a negative thing after all, which is, of course, a big relief. Now, I put here on the bottom for the next slides, I have a few more of these, some sort of observations, I guess, of items, of things that we don't know yet really about PBF. So we can talk about those more. I think these are sort of areas for research. One is that, as I said earlier, we don't really have a good sense of what is the sort of impact of PBF more broadly outside the non-targeted services. A lot of evaluations don't look at those. And then there's a question of whether there's heterogeneity across different groups, different types of facilities, sort of different population groups, different kinds of health facilities, and sort of to understand that better, partly to know where PBF can actually be useful and where maybe it doesn't work very well. So I think that evidence is still outstanding. A lot of the research has been sort of on the average effects of PBF, and I think that's a key limitation right now of the existing evidence base. Now, one interesting question, of course, is given that we have mixed effects, is it actually worth it? And of course, in PBF, we sort of pay incentives, we give money to people, so that's a cost, but there's also additional costs. And I put here sort of from the very few costing studies that we have, sort of an overview. This Tanzania program in 2012, of course, is a bit old. But you can see that there's a huge amount of money that gets spent on data generation and verification. So there's sort of new costs that are unique to PBF that are sort of very expensive, and of course make the cost effectiveness of PBF sort of make it not as cost effective as it otherwise could be. And I think these are sort of interesting items to think about. If we wanted to improve the cost effectiveness of PBF, we could sort of find ways to increase the impact and maybe sort of subset the PBF to certain population groups or certain types of facilities, but also maybe bring down the cost, especially when it comes to data generation, like reporting at the facility level, what they've done. There's a lot of documentation involved in PBF, partly because, of course, money is involved. And so in the public sector, whenever you want to disperse money, there needs to be a lot of documentation and checking. And that is now done at the facility level and is sort of costly in terms of human resources and in terms of time. So it's sort of interesting question how to bring down these costs. But I think, and sort of the overall picture is that PBF might actually not be relatively cost effective. So we might actually prefer to use simpler approaches like just giving facilities more money and sort of enhanced financing, maybe with additional flexibility on how they can spend it, rather than having this entire machinery that is performance-based financing, which involves all these reporting and verification channels. And so maybe there's other ways to actually get facilities to perform better, and relative to things as simple as enhanced financing, it seems that PBF is not necessarily the best choice when it comes to cost effectiveness. So I think this is still a very interesting area for work, and partly, as I said, to sort of figure out how to bring down the cost of data generation. We've done some work on sort of using predictive analytics for risk-based verification and sort of finding ways to reduce this verification cost a little bit at least, and that there's a lot of potential for using data science, for example, to use the existing data and do these kinds of predictions and bring down the costs. And clearly there's a lot of potential for using electronic data systems to reduce the burden of data generation. And I think this 2012 data point in that way is outdated. I think nowadays the data generation costs are lower, although it's still a big burden, especially on health facilities, to actually do all this documentation. Now here's some success factors for PBF, just to sort of flag that there is some sense that these programs work better in some settings than others. Although, as I said, this is at the sort of scheme level, not so much at the level of individual facilities or types of facilities. I think sort of the general concern is that these programs are rushed into existence and into implementation. They divert a lot of resources from health staff, both at the facility, but also at, let's say, at the Ministry of Health level. And sort of these schemes work best, of course, if there's actually proper context in place and proper structure in place to make these things work. If health workers actually understand how the scheme works, which is not a given. In some studies, they find that 50 or 60% of health workers do not understand at the outset of how this PBF scheme actually works. And so they don't really know what they're supposed to do. And then, of course, you shouldn't expect any impacts on these outcomes. So all these things take a bit of time, and clearly there's some scope for sort of doing the implementation right and making sure that the impact is high enough. Now I'll just highlight a couple of other issues that come up in PBF, and then sort of conclude with some ideas for research. And so just bear with me for, I think, 3 or 4 more slides, and then we'll get to the discussion piece. So I think one thing that we don't know a lot about actually is what happens as PBF programs mature, both in terms of as they evolve, maybe they change over time, and then what the long-term effects are of PBF programs, and more generally, what is sort of the sustainability question? Can they be taken on by countries? Now, on the first item, there's sort of a question of how the programs are designed in the first place, and how that comes about, and then how they should change over time. And what we've seen in some work we've done is that if these programs sort of go through revisions, they tend to just expand. And so there's this sense of mission creep a little bit. They tend to add more stuff rather than rationalizing what they actually do. They tend to expand the number of quality indicators, sort of structural quality indicators, rather than changing how they measure quality or sort of innovating around those margins. And they sort of increase the payment rates rather than sort of thinking about what services to include and what these rewards should actually look like. I've done some work on the question of scaling up and medium-term effects. That's something that normally these pilots cannot look at. These impact evaluations are all aimed at sort of the 18 to 24 month span. And then the question is what happens once these programs sort of expand to national level and sort of remain in existence for a few more years. It's possible to use demographic and health survey data, so secondary data, to do country sort of implemented PBF, compare it to situation in neighboring countries. And for that, we find that at least in a place like Rwanda, which of course is sort of a leader and sort of likely to do well in many programs, I guess, if you find that this scale up is successful and there are actually additional impacts in the medium term. So the impact of PBF grows over time beyond the short term. And that's, of course, a very promising thing. But again, sort of Rwanda is maybe a little bit special in those kinds of ways also. And then there's some PBF, some evidence that if PBF ends, like these pilot programs that are supported by the World Bank in some places have ended, and the governments have not taken, or the countries have not taken on these programs into national policy. And clearly, once you get sort of paid something that is maybe 15, 20% of your wage, and that gets taken away, that can, of course, be very frustrating. And in fact, it seems that sort of removing the PBF bonus is maybe possibly worse than just lowering people's salaries. And so sort of the sense that, don't get paid anymore for performance seems to be worse than just removing money from them. There's a little bit of evidence that sort of pushing people initially with PBF could also just sort of nudge them to do the right thing, sort of maybe communicate to them what are the kind of things we would like them to do. And then there's some evidence of persistence effects and things like labor and delivery care in places like Argentina. So I think these bottom pieces here, this temporary effect is sort of, there's some evidence on this, but not a lot. And it would be good to have a little bit more on this to see if things sort of, once you put them into place and once you get people used to doing certain things, whether that sort of persists over time. We just don't know very much about that yet. There's the issue on sort of broader health systems. There's an interesting debate going on in the PBF space, whether PBF is really just distracting and taking away resources from governments and from donors and so forth that could be used otherwise. Clearly, these programs involve a lot of machinery and require a lot of attention and sort of administration, and could be distracting in some ways. And the opposing view would be whether PBF is sort of an entry point into larger health systems reform. And I think this is sort of, this debate, I think, probably shows up in other areas as well, like whether a particular focus on a particular intervention is very distracting or is sort of something that could be leveraged into larger systems change maybe. And that debate is still a little bit out, though I would say that, I think in terms of at least the negative effects of PBF, I think that the evidence is a little bit limited, but it's certainly true that they do require a lot of attention and resources. Some last questions, maybe on the more sort of conceptual and academic side. I think there's sort of the sort of practical question: what designs work well in what kinds of settings? And I think there's a lot of scope for implementation research to look at these kinds of questions. And then there's these sort of more conceptual issues of what is it about PBF that actually generates improvement? Do we need financial incentives at all? Could we just give non-financial incentives or some other forms of recognition? What do these rewards need to look like? Do we need to pay a lot for providing for delivering a facility delivery, or does any positive price is any positive price enough? So if we use PBF to signal to providers what we think is important, then maybe it doesn't matter how much we pay them. It's just enough to say, like, these kinds of services are so important to us, we're willing to pay you for them, so please pay attention. And if that's the case, then maybe we don't really require to sort of add a lot of bonus payments to it. It's just a sort of small signaling device. And then, as I said earlier, there's this question of whether we can achieve what PBF does just using simpler approaches. So if this is about giving discretion to facilities to spend money, or sort of small discretionary pot of money to facilities, then maybe we could just do that rather than having the entire machinery of PBF. And I sort of, the question, I guess, is whether we need PBF to make sure that these things can happen. So you can, from the policy perspective, see PBF as sort of as a way of getting health systems to adopt these good practices, give discretion to facilities on some things, so they can fix local issues with sort of their own capacity in their own way. Do we need PBF for this, or could this just happen without PBF just by itself? And then finally, let me just flag a few sort of areas which I think are sort of ripe for research, including interdisciplinary research. And I'd love to hear your thoughts and sort of questions on that as well. So as I said earlier, there's lots of these PBF pilots, and one thing that's really nice about them for the research perspective is that they often have rigorous evaluation designs. Many of these are randomized trials, and even if you don't use the data that comes with these research studies, you can use secondary data, for example, like demographic and health survey data, to just make use of the trial design. So we've done this in Rwanda, where it was randomized on the district level. And if you have DHS data, you see district level information, you could just sort of reevaluate and extend the existing trials, existing evidence that exists. And sort of that's a very, very nice thing to do. And that's possible in many of the countries where the World Bank has supported PBF pilots. There's also a lot of scope for implementation science. As sort of said earlier, these programs they're all sort of similar in some ways, but different in other ways. And certainly these pilots themselves have a lot of variation in what they actually test in practice. So there's a lot of scope to learn from that across different programs. And even if you're not interested in PBF, maybe you're interested in the data that comes out of it. One thing that PBF, of course, does is generates this new routine data that comes on every quarter or every month or so on performance and on quality of care. And it sort of adds into a larger data set of health management information systems. The nice thing about the PBF data is it's also verified, so the data quality is pretty good. So there's, you can use that data to just better understand the situation on the ground, to design additional interventions or maybe target interventions to certain populations or types of facilities. And so this is irrespective of whether you are interested in PBF, the data is a useful resource to have. And in fact, what PBF proponents might say is sort of one of the benefits out of PBF. My sense is that this data actually doesn't get used a lot right now, but there's certainly a lot of scope for using it for research and policy purposes. And then finally, there's sort of a lot of scope for research to sort of improve operations, maybe reduce costs or improve impact. I mentioned this work that we've done on risk-based verification. There's a lot of good work to do on that, I think, just to bring down the costs of PBF programs. You can think about enabling new indicators like outcome quality measures. As I said, the sort of patient satisfaction is one of the key outcome quality measures that we would like to have. And it's very difficult to collect because it's expensive. So one could think about doing automated patient surveys in whatever way, phone surveys or whatever that might be, to measure patient satisfaction, at least in some basic way, and thereby sort of improve these programs. So with that, maybe let me stop. And I know this was a lot, and I hope sort of stimulating, and happy to take any questions. I realize I probably went over my 30 minutes. As I was warned by Jan, I might probably end up doing, so apologies for that. But happy to take any questions or comments and also stick around a little longer. Thank you.
Thank you. Thank you very much, Sebastian. This was certainly extremely interesting for us. At Center for Development Research and in the transdisciplinary research area, we have some focus on health, health insurance, One Health approaches. You have colleagues from the various communities in the audience. I suggest you remove your PowerPoint then I see a few more faces or hands that may bring up questions. While I wait for a few hands to come up, some clapping hands are already virtually clapping on the screen. I think what you brought us is of great interest for us in the research community in the transdisciplinary research area on sustainability. I have taken notes that the PBF is also expanding rapidly in the education sector in emerging economies. And there are also by now a few hundreds in the field of food, nutrition, and rural development changes. So PBFs for getting the fertilizer out and stuff like that. So it interests us as an example from the health sector, but also more broadly from development incentive thinking. Of course, colleagues have now, while I was belaboring your talk, I see 5 hands already, and let's get started with them. Monika Hartmann takes the floor, please. Then Jan Börner, Niklas, Kurosh, and Alicia. Please, Monika Hartmann.
Yeah, thank you very much.
Voice louder.
Okay, can you hear me better?
Very
okay.
Good. Yeah.
Sorry. Thank you very much for this exciting and interesting talk. I'm not sure whether I missed those 2 points, so please excuse me if you mentioned that. But one issue is, you said many of those programs have been initiated by the World Bank and were kind of pilot programs. Is there any kind of analysis which shows what share kind of was put into national policies after those pilots kind of were terminated? Because I do assume that the World Bank is not financing these issues over, forever, let me put it like that. And then you started at the beginning indicating to us that there's quite a bit of mortality on the side of the mothers and the children. And are there studies which kind of clearly compare also how mortality is declining with different programs, like programs you presented, but there could be also programs where you just subsidize the health system and maybe subsidize it, especially in regions which are extremely vulnerable, because I would assume that makes also a difference, because also in these countries you do have certainly a different situation in different regions. So a little bit on the numbers concerning the future of these programs after financing from the World Bank is terminated, but also regarding its effectiveness compared to other programs.
Would you take it right away?
Yeah, let me take it right away. So thank you so much for the question, Monika. This is a good question, of course. I think on the first part of what happens to these programs when sort of the World Bank leaves, that's an interesting question. I don't think there's any good sort of summary of what happens actually as that happens. This trust fund, the HRITF, is about to end next year, and it's currently already rolled into the global financing facility at the World Bank. So there's a continuation that sort of the World Bank has. And in some ways, this global financing facilities is about sort of health financing, more largely than more than just PBF, but I think the PBF programs remain an integral part of what the global financing facility does with countries and how they support countries. So I'm not sure exactly how many of these pilots have sort of made it into national policy. There's some sense that, you know, they've sort of implemented them and scaled them up, but I'm not quite sure exactly where that stands. And I don't think there's any good, not that I know of, not any good write-up of how this has happened in practice. My sense is that the global financing facility supports a lot of these programs still in many countries. So it hasn't quite ended yet. And I think they're certainly interested in continuing that work. The World Bank is, for sure. So I'm not quite sure exactly where that stands. Okay. But it's a good question. I will say that the trust fund itself is being evaluated, or has been evaluated twice by the Norwegians, and they have their reports, sort of process evaluation reports, online, and I'll put one, if I can find it in a moment, just in the chat box, in case that's interesting to you. There's a lot of interesting bits and pieces of how this all works. On the mortality effects, so the health effects, here I put into the chat a paper that we've just published on impacts on neonatal mortality. And I think the sort of main lesson from that is that these programs do not seem to have a huge impact on mortality outcomes. And maybe to some degree, again, this may be not surprising. Of course, mortality is sort of very far out in sort of the results chain and the theory of change of these programs. There's a lot of factors that come in, and the facility is only one part of it. And we looked at neonatal mortality because at least that's very close to sort of the birth, labor, and delivery sort of care provided. But even there, across a couple of programs and PBF programs, we don't really find any impacts. Part of that is, of course, because we didn't see very many impacts on utilization in the first place. And so I think these sort of changes that PBF can bring about are relatively small and mixed, and ultimately don't seem to contribute too much to things like mortality. But maybe they move the needle at least a little bit. Yeah. So sort of, given that there's not a lot of impact of PBF on mortality, as far as I can tell from our programs, from our analysis that looked at sort of African programs, you know, there's not really a good comparison to be made. So PBF doesn't seem to do much, and any program that does better is better in that sense. There is some evidence, I would say, from Argentina, again, that sort of suggests that it can actually have impacts on mortality and sort of outcomes like stunting, sort of morbidity type outcomes. So there's some evidence floating around, but sort of for most of these PBF programs in Africa, I have not seen anything beyond what we have done.
Jan Bonner.
Yeah, thank you. You mentioned at the beginning that the concept of performance-based payments is being applied in several sectors. I'm most familiar with payments for environmental services. And there are two recurring themes in that literature that I was wondering whether they pop up in your sector as well. One is on incentive crowding in and crowding out, sort of these intrinsic incentives to provide something. Are they being crowded out by a performance-based payment, or are they being crowded in? The typical critique of PES is that if you pay people for providing environmental services, you crowd out the intrinsic incentives to provide them. Is there anything like that in the literature you're talking about? And the other theme that recurs in that field of literature is targeting. So how do you, where do you provide them? Do you provide them to all potential providers of ecosystem services, or do you provide them to just certain places where the gap, the no-do gap, how you mentioned it, is largest? And would that be a way to increase efficiency? So I'm just wondering, is there anything you can say about that in your literature?
Yeah, so that's a great question. Yes, there's a little bit of work on the workers, of course. I think this has been a sort of a main concern of many sort of public health and health systems researchers, that this could sort of affect intrinsic motivation. I think the main takeaway from what I can tell is that you know, that workers are generally satisfied with PBF. I think they appreciate the sort of the nudges to be maybe paying more attention, to be told what the priorities are, and so forth. So my sense is that this is actually a good thing. There's some work on sort of using self-determination theory to actually properly study how workers respond to these kinds of incentives. And I think overall it's sort of generally positive, and maybe there's some frustrations that come from the sort of deficient implementation of these programs. As I mentioned earlier, there's sort of the sense that maybe the bonus payments come late. Clearly that'll frustrate people, just like it would with any other payments that they might receive that are late. But I think in general, it seems that there's sort of a feeling of recognition, if anything, could be reinforcing intrinsic motivation. So if you're interested, I'm happy to share a few more sort of sites on this. There's some interesting work done on some of these PBF programs in Burkina Faso and Malawi that actually suggests it works quite well. And I would say that, you know, I think it's interesting to think about the application of this in other sectors. Joachim already mentioned education. I think that's an obvious one where there's lots of parallels to health as well. But even the examples that you sort of mentioned as well, Jan. Health is a little bit complicated, I think, in general. So I think it's sort of, you know, lots of sort of nuances to this, but I think the general lessons still apply in other places, of course. When it comes to targeting, I think that's an interesting question. The programs that I sort of talked about are mostly in public sector. And so it's difficult to exclude certain kinds of facilities from getting extra payments or bonuses. But what many of these programs will do is sort of increase the sort of value of the financial rewards, the incentive payment to facilities that are in difficult, sort of challenging environments, like in rural areas or with hard to reach populations and so forth. And there are some PBF programs in conflict areas as well. And so I think it's possible to deploy these programs in a sort of more strategic and targeted way, sort of to use them where they can be useful and so forth. And these programs mostly target facilities rather than workers directly. So I think that's probably the level of targeting that you would have to do, or the level of the district or something like this. But certainly there could be variation in how these programs operate across different areas and so forth, to the degree that it's sort of allowable within the public sector to have any differences in policies for different places. That's maybe sort of more political constraint than anything. But I agree. For what it's worth, I think that that's partly what I mentioned with this heterogeneity analysis. I think my sense is that these programs can be incredibly impactful in the right kind of context that they've implemented in the proper way. But maybe as sort of an average and across an entire country, maybe the effect just gets diluted. And so I think sort of looking at this and saying these programs don't work is probably the wrong takeaway. I think the right question is, you know, what is it about these programs that could work, and in what circumstances does it work? So rather than to sort of throw out the baby with the bathwater, to just use it as a learning opportunity to figure out what we can take away from this, also for other sectors.
Niklas?
Yes, thank you for the nice presentation, and going back to some of the points that have been just discussed. I think one of the difference with environmental story is PBFs there are usually to pay for public goods. You are talking of mostly private goods, so it's more like education, as you said. But in education, I think the consumers or the patients don't really pay for what they get. Yeah. So in your case, I would imagine that there's a more direct relationship between the customer or the patient and the person that is providing the service. So I did not see much of a discussion in your presentation about the demand side of things and what are the different conditions of the demand side there. Maybe when patients are actually paying, or if it's all subsidized by the public health service and these patients are just sitting there and getting it all for free, and how this all sort of impacts on the results.
Yeah, thanks so much, Niklas. I completely agree. So the programs that I talked about are mostly about sort of public sector, primary care level, and that's often free in many countries. Certainly these basic maternal child health services. Some of these programs cover immunizations that are free anyway and sort of have multiple ways of outreach. So I think, you know, the sort of price component is maybe a little bit less important. What I showed you earlier, this sort of comparison of, you know, if you send the same patient to the same doctor working in the public or private practice in India, I think that's where you can see the difference in how much it costs and where the price is important. And I think there is a sense that, you know, providers that provide higher quality will charge money for it. So I think that's definitely true. But in these sort of programs that I talked about, many of these services should be provided for free, which is just to say that, you know, once you're at the facility, maybe you don't pay for the exam. You might still have to pay for your medicines, and you certainly probably have to pay for getting there in the first place, your transport costs and other kinds of things. So it's sort of free in this sort of sense that, you know, the health workers are salaried and they get paid by the government. So that should be coming for free. But it's a good point. I think there's sort of this special vibe to the public health sector, just like there is to education as well, where you might pay for textbooks or something like that.
Karush Kabir.
Thank you for your talk. Very interesting. Maybe my question is wrong here, but I would like to ask it anyway. I am an orthopedic surgeon who's working at the University Hospital here in Germany. And if you look at it we look at the low income nation, what about high income nation or Western countries? How do you see that? Is it possible to do like performance-based financing? Because in Germany, as you know, I don't know, they plan something like that the quality will be measured and dependent on that. What do you think about that?
Yeah, so
Thank you.
The pay for performance has been sort of around in high income countries as well. The US has done a lot of this, both in sort of the private sector and in the public sector in the Medicare program. The UK has a big pay for performance program. I think I think there's many things to say about this, I guess. One thing that's very different in these settings, of course, is that they have much better data systems, a much better way of reporting. In the US, they use things like readmission or mortality or something like this that they can measure from administrative data, which is really quite powerful, of course. And this looks nothing like what these health clinics look like in low income settings, of course. So I think my sort of general takeaway from the pay for performance literature in the US is that these programs are normally very targeted. They might be just about a specific type of service or a specific specialty. And unless it's the UK where they really did a lot of different items. The payments are usually much smaller than what I showed you. So in places like Rwanda, 25% of the facility budget comes from the bonus. These are really top-up payments. I think they can work in some settings. I think the way that they've been implemented in places like the UK is maybe not fantastic. They certainly overpaid. So I think there the money becomes a big issue very quickly. And so I think they have a role. I think one thing that's interesting about these about pay for performance or performance-based financing, sort of same story, I guess, is that they're very different from traditional financing, and I think they really do put people on notice in some ways. It could just be a communication tool. You say that these are the kind of things that we find important. Please make an effort, and we find it. We think it's so important that we're willing to put money behind it, and I think that sends a very strong signal and a strong reminder maybe of what matters. I think hospitals pay attention, and providers might too.
Mm-hmm.
Thank you.
Alicia?
Thank you very much for a very interesting presentation. I was wondering if you could talk a little bit more about the economic theoretical background behind PBFs. We talked about this, what may happen when the short-term PBFs end. We also hinted at possible detrimental effects, but I was wondering if we apply Friedman's permanent income hypothesis to this situation, and we see that people would respond to the permanent changes in their income rather than this short-term transient changes. So if health workers know that this is all a short-term program, then also I wouldn't be surprised if they don't change that much their behavior. So, but you mentioned also Rwanda, which is applying, it seems to be applying it long-term, in a long-term way or in a permanent way. Is there anything to learn from that in terms of this, causality, economics aspect? What is driving this PBF performance? Thank you.
Yeah, thanks. That's a great question. So I think we don't really know very much about these long-term effects. As I said, there's sort of a sense that, maybe providers don't do the kinds of things they should be doing and they know to do because they sort of just forgot that they're important, or so that they don't pay enough attention. And so in some ways you can think about these sort of performance-based payments as a nudge. So there's a reminder of what should be important. And that could, of course, once they sort of get them used to this practice, could, of course, get them used to sort of doing it. And then even if you withdraw the incentives, they might continue doing it. So this is more like a learning type story. You could imagine that, you just use this performance-based financing to sort of remind people and to teach them what is important. And so that's more like an economic sort of model of learning, and whether they sort of maintain that level of productivity, whether these effects persist. So the generic sort of PBF stories is what I said earlier, is this principal agent framework that we just sort of design our contracts with providers in a way that aligns the incentives. Now, of course, when you then withdraw the incentives, then they might just go back to what they've done before. And so I think it's mostly still an empirical question, what actually happens to providers once you sort of get them used to a particular standard of care and particular actions that they do and the way that they interact with patients. Once you get them used to that, do they continue doing it or do they stop doing it? I think we don't really know this very well. I mentioned this one paper from one study from Argentina that does seem to find that when the PBF sort of is temporary and ends, that providers continue doing the good stuff they started to do when the PBF began. But in principle, of course, there's no reason why they shouldn't, stop doing it. So they might as well just not do it. Once the incentives end, they could just save themselves the effort and not do these additional exams and so forth. And maybe to some ways, this is sort of speaks to the intrinsic motivation as well that Jan was asking about. So maybe providers do want to do good, and you sort of give them the right nudge, and then they sort of learn what is good. And I think if you speak to providers in any of these settings, they will say that they really appreciate these PBF programs because they sort of help them focus on performance, give them some priorities to look out for. And so I think it's possible that they just use this as a good reminder and then continue doing it. But they have no reason to. And I think mostly it's still an empirical question whether they actually do that after the programs end. So I wish they had a good answer for you, but I think this is an interesting research question. And now that many of these PBF pilots are ending and either become national policy or not, I think those are the kind of questions one could ask.
Sebastian, I see there is one more question, but I would like to ask one from my side before giving the floor to Cecilia. In the past couple of decades, lots of countries, of low and middle income countries, have rolled out insurance schemes, rural health insurance schemes. China set the standards, rolling out from 0 to 90% coverage in rural areas within 6 or 7 years. India is still on the same track. African countries are progressing as well. So first question, how do PBFs in the health sector dovetail and enhance rolled out insurance schemes? How do you deal with the counterfactors in a dynamic field of changing the insurance situation? And more specifically, can you point to any counterfactual testing where vouchers were given to the patients, so the capacity to pay to the client rather than to the nurses and the hospital organizations in a health insurance environment?
So I think on the former part, I think many of these PBF programs target primary care level, and some of these insurance schemes at least are focused on sort of hospital care, places like India, for example. So there's a little bit of a divergence there, although I would say that they do interact. PBF includes, for example, incentives for appropriate referrals. So a primary care clinic that sees a patient should only refer a patient that actually needs to be referred to higher level. And if they do that properly, then they actually get an incentive payment in many of these countries. So there's sort of that part. The insurance maybe tackles a slightly different part of the care system than PBF does. Now, it's tricky to think about, when these programs get rolled out all together, of course, the counterfactual becomes very tricky, as you said. I think one thing that's nice about the PBF pilots, maybe many of them happened a little bit before this insurance expansion came along, but also they are often randomized, as I said. So even if the insurance is sort of a national policy, it might still be possible to compare areas that have insurance plus PBF versus areas that only have insurance and look for the synergies between those. Now, I'm skeptical that you would find anything empirically because we think that the impact of PBF itself is so limited, so mixed rather. So I would sort of be surprised if there's anything there. But certainly from sort of a process evaluation and qualitative side, there could be something interesting. I haven't seen any studies on this, and I would be interested to know what the overlap is between this insurance rollout and the PBF implementations. Now, as I mentioned, some of these pilots that the HITF supported include demand-side interventions. So some of them actually look at a conditional cash transfer, sometimes the intersection of conditional cash transfers with performance-based financing on the supply side, or sometimes things like user fee exemptions, which I think sort of conceptually are maybe similar to the insurance piece. Certainly get access to care for free, or maybe if it's conditional cash transfer, you might get a voucher, as you said, that would have covered travel costs and other kinds of costs as well. So I think there is this overlap, and I don't have a good sense of what the sort of specifics are of the evaluation of, let's say, conditional cash transfer versus nothing. But I think when it comes to the interaction with PBF, we should be seeing in the next year or so more evidence coming out of the World Bank. They're doing these evaluations and finishing them up. And certainly if you were interested in studying this, you could probably find countries that do these multiple arm trials and do an evaluation on it using secondary data.
Mm-hmm. Thank you. I see two more questions, then we will wrap it up as we are over time. Cecilia, please take the floor.
Yeah, thank you for the presentation. And mine was just a technical question regarding what happens to performance. Is there a punishment, or now this is such a reward scheme, is there like a punishment to take something away so that they perform better, or it's just geared towards performance? Thank you.
Yeah, well, that is a great question. So this is a partly a design question. We know from psychology and behavioral economics that sort of using a penalty rather than a reward might be more effective if it's the same amount of money. Many of these PBF programs do not use, or most of them do not use penalties at all. This is maybe a distinction, Kourosh, with sort of high income settings as well, where these are more set up, sometimes more set up as punishment. You know, if you sort of your readmission rate is too high or something like this, then you get some payment withdrawn. And these PBF programs that I talked about, these are almost exclusively bonus payments. And I think there's an interesting question whether they could be more effective as sort of if you were just to take away money. So if you give people sort of, let's say, $1,000 or something like this, and then if they don't perform well, you take away some money. We have some work that looks at this. It doesn't seem like there's a huge difference between giving a reward or using a penalty on top of it. But I think the other reason why we don't see this in practice quite as much is that, you know, these PBF programs, you could look at them and I say, like, you know, these are all about setting the incentives right for healthcare providers. Or you could look at them and say, like, this is just a new way of getting money to the front lines. So we know that these facilities and these workers are underpaid and understaffed and under-resourced. We'd like to give them more money. And here's a sort of instrument that lets us do this in both sort of a maybe conceptually appealing way, but also politically feasible way. If you go to Ministry of Finance and say, we want to pay our frontline workers more, they will say, like, what are you talking about? We don't have any money. But if you go to the Ministry of Finance and say, you know, we want to pay for performance, and then the Ministry of Finance might open up its pocket and sort of help you do this. And so you could look at this as sort of just a sneaky way of getting more money to the front lines, in which case you definitely want to pay people a bonus as well and sort of give people more money. And I think it matters for perception and sort of understanding as well. I think for health workers, you know, they are stressed about their salaries and income. And I think if you were to sort of raise the potential of punishment, they might not like it quite as much as they might like a bonus, even if it's the same amount of money. So it's a framing issue partly. That's a great question. Thank you.
Well, colleagues, let me wrap it up. I think Sebastian Bauhoff has given us a lot of food for thought in the field, in a rapidly evolving field of performance-based financing. This is not just a Washington-based thing. I see more and more NGOs interested in performance-based financing, including here in Germany. For instance, Welthungerhilfe, we had discussions in the context of emergency assistance, getting the job done. We mentioned ecosystem services, Jan mentioned that, and agriculture and education programs. I think we would like to take you up on your invitation or suggestion to use these data sets and combine them intelligently, maybe with household level data sets and with health outcome data sets, because somehow we need to understand if this mouse if this cat catches mice, if the effect on health is positive. Otherwise, it may be doing good for personnel at the front lines, but in the end, we are interested in the outcomes at people level. I'm sure we would have another round of good discussion, wondering how PBF might function under COVID-19 conditions, under the pandemic conditions, which changes lots of parameters, and how health systems withstand the shocks that coming from that. But time is limited. but there's no limitations on ideas, Sebastian, which you have shared with us. Come again, follow up with us in the cooperation which we can offer in the field of transdisciplinary research area number 6. And with that, I would like to close the meeting and thank you again.
Thanks so much, everybody, and I hope you found this interesting. And please do reach out. I really would love to do some more work on this, and I would love to learn from all of you how this might apply both within and outside health and looking at the health outcomes and all that. So please do be in touch. Thank you so much.